So thank you, Dr. Ann and Organization of Rare Diseases for this opportunity. I think it's really good to have connected with Dr. Ann since I moved to Bangalore a few months ago, because she's connected me with the right community. And it's really good to be here. So my background, I've been in the UK for the last 20 years, working mostly in Birmingham for the last 14 years in metabolic bone diseases. So I'm still affiliated to Birmingham and also the University of Birmingham, where I did my PhD on metabolic bone diseases, and I continue to do some weekly clinics for them. So today's session is going to focus on bone health and osteoporosis in neuromuscular disorders, but in particular Duchenne muscular dystrophy. So I'm just going to sort of go through the pathophysiology of bone fragility in neuromuscular disorders and review the evidence base for what is the best practice to manage bone health, or monitoring and screening, and how to manage with DMD as a case example. And then I'll briefly in the end touch upon what the current clinical practices are and what's the emerging approaches, because there's a lot of new bone targeted therapies coming up. So I'll touch briefly on these. So just very briefly, I must talk about the mechanostat theory, because this is the basis for why we see bone fragility in children with neuromuscular disorders. So this is a theory which was proposed by Harold Frost, who was an orthopedic surgeon by background. So basically what this says is that when the muscles act on the bone, that is the strain that is required for bones to grow. So when this is lacking, bones don't grow in width and don't strengthen. So muscle action on bone is extremely important for them to get bigger and for children to develop a strong skeleton. So what you can see here is the X-ray of a child with SMA type 1 on the left and the normal one on the right. So as you can see, the width of the child with normal growth and development, the bone width is much bigger. So if you take two rods of the same height but of different width, if one is double the width, its strength increases by 8 times. Okay, so that is why children with low muscle tone have narrow bones which break easily. And again, these children will grow in height. So if you take two rods of the same size, but if one is much twice as tall, the bending strength of that will be lower. It's 1/8, which means they don't bend, they will break. So bone width is one of the most important determinants of bone strength throughout a person's life. So if they lack this in early development, then the bone will be predisposed to fracture throughout. So coming to Duchenne muscular dystrophy, I think I don't need to tell this cohort, you've all dealt with these children and young people. So this is an X-linked recessive neuromuscular disorder, which is characterized by dystrophin deficiency, which leads to progressive muscle degeneration. So in this condition, ambulation is typically lost in early adolescence, and in later life, they tend to have more respiratory and cardiac complications. So unfortunately, the paradox here is we need corticosteroids to keep them moving, which is important for bone health, but we all know that corticosteroids are osteotoxic. So that is the challenge that we face with in managing children with this particular condition. So the pathophysiology of osteoporosis in this particular condition, there's progressive muscle weakness and immobility, and this reduces osteoblast stimulation, which compromises bone formation, as we saw based on Harold Frost's mechanostat theory. And then come your glucocorticoids, which directly suppress osteoblasts. They increase osteoclast activity. They impair calcium malabsorption. These are only some of the top reasons I've quoted here, but we know there's more mechanisms that we don't quite understand how glucocorticoids affect bone health, but there are a multitude of factors. And lastly, delayed growth and puberty, extremely, extremely important, because a lot of these young boys will have a short stature and delay in puberty, and that is extremely important for peak bone mass attainment. The testosterone exposure, the later it is, the lower the peak bone mass attainment. So it is very important to look at this as well. So why do we need to optimize bone health in boys with DMD? Now, we know it improves quality of life, and there are reports that it may enhance survival as well. and bisphosphonate therapy for osteoporosis has been linked to increased life expectancy. So it is really important, mostly for quality of life, that this condition is managed well. So I'll take you through a case study and we'll talk about how we went about managing this child. So I've just called him Master X. So he presented
Dr.
typically
Suma?
with treatment faults. Yeah.
Dr. Jayanth has joined.
Oh, hi, Dr. Jayanth. Do you want me to pause or carry on?
Because
yeah, please go ahead.
Please go ahead. Okay.
Yes, please.
Thank you, Dr. Jayanth. So Master X, he presented with frequent falls and difficulty climbing stairs at 2.5 years of age. Further investigations confirmed diagnosis of DMD. And more recently, I think people are starting steroids at a younger age. However, this is a slightly historic case. When they started plateauing motor skills, they would start steroids. So he started at 6 years of age. He was started on daily prednisolone. So the 4-phase management framework, which was proposed by the recent DMD Care Consideration Working Group in the 2018 consensus, talks about prevention and monitoring in phase 1, stabilization, maintenance, and then considerations for discontinuation of treatment. So in the prevention phase, we are talking about supportive therapy and also screening to identify early signs of compromised bone health. And then in the stabilization phase, our main aim is to mitigate any back pain, interrupt the fracture-refracture cycle using bone-targeted therapies. And then once we've attained the bone density or clinical goals that we want to achieve of stopping fractures, then we have to think about how we hold the young person or the child in that phase. And then finally, when they've completed growth, when you've got a good bone density, no further fractures, vertebral fracture healing, then we have to think about where do we go from here. So firstly, coming to the preventative measures, it's really important to maintain optimal vitamin D levels, which all the neuromuscular consultants and teams are very good at doing. So they have to have vitamin D levels above 75 nanomole or 30 nanogram per ml. And this is ideally done by daily vitamin D supplementation of 800 to 1000 IU per day. If it is really difficult for them to take daily, you can do weekly of 5 to 6,000. But I would really discourage from doing the 60,000 treatment, because in the younger ones, we know this can cause hypercalcemia. And also in others, there are studies which have shown this causes downregulation of the vitamin D receptors. If you think of any hormone, they all work on a feedback mechanism. Similarly, so does vitamin D. If you give a high dose like 60,000, the CYP24A1 pathway is activated and vitamin D gets degraded. The reason we don't see this in a lot of studies is because nobody measures 125, which is the active form of vitamin D. So it's really important to give them daily supplements, because you wouldn't ask someone to take levothyroxine once a month. So we shouldn't be doing that for vitamin D either. And calcium supplements, again, calcium is something which is easily obtained in diet, as long as they have good dairy in the diet and taking adequate amounts orally. So you can try and achieve this orally. Where you feel you cannot meet this orally, then you can recommend supplements. So again, I think you guys are better at doing these than endocrinologists, the neuromuscular team. Encouraging physical activity or physiotherapy, stretching, anything that can keep the muscle action going on the bones will help encourage bone growth and growth in height as well as weight. And nutrition and weight management is another very important aspect. I think increasingly, as we've come up with newer treatments, increasing lifespan, we are paying more attention to all the other aspects of care of DMD, such as the weight management. Currently, I'm part of a UK consensus group where we are coming with some Delphi consensus guidelines for weight management in this group. And also we know there are emerging therapies for weight management. So there will be a role for these therapies in boys with DMD as well. So we start this at the point or just before they go on steroids, because that also we know adds to this burden. So back to our patient. So he had a normal bone profile or borderline vitamin D, for which he was commenced on 1000 IU daily of cholecalciferol, and dietary calcium was assessed. It was thought to be adequate in diet, so we didn't supplement him. They do all get a diet and nutrition advice at diagnosis and also physiotherapy. So how do we go about monitoring his bone health? So a comprehensive fracture history is very important to take and document at each clinical visit, not just baseline. And then the most important investigation is a vertebral fracture assessment, because the classification of osteoporosis in children has shifted from bone density focus to vertebral fracture focus. And this has come about because of the cohort of boys with Duchenne muscular dystrophy, where we see a lot of vertebral fractures. And then comes the DEXA scan. And in DEXA scan, the ideal sites to measure are total body less head and lumbar spine, because this is what contributes to future fracture risk. And these are the sites which can be reliably measured in children. And we start scanning children at the age of 5 years, because that's when the reference data for children is available for. So why do we need to, sort of monitor this? What is the disease burden in these young people? So low trauma vertebral fractures, or fractures which are mostly caused by glucocorticoid treatment, are very frequent in this cohort of children, but they go unrecognized because a lot of the time they can be asymptomatic. So when they are mild, they are asymptomatic. Only once they start to progress, they become painful. And once you've hit that stage, there's pain as well as spine deformity, and this increases their fracture risk further. And about 60% of boys with DMD will have low trauma extremity fractures as well, the femur, tibia, and fibula being the common sites. What you're seeing on the right side here is a vertebral fracture assessment image, which is obtained from a DEXA scan. You can do this on a DEXA scan or an X-ray, but it looks much better clarity on a DEXA scan, depending on the make and machine of the DEXA scan. It looks better because you can capture the whole spine in one image, and also the interference from the lung is less on the DEXA images. So back to our patient. So traditionally what we have done is these boys have been referred around 9-10 years of age to our service, but increasingly now we start to see them from 5 years of age. When we can do a DEXA scan, we start scanning them. Some of them, if they're not on steroids, we put it off for a year or two. Others, if they have already been started, we start scanning at 5. So our patient had a vertebral fracture assessment, which looks fine, and he's had a lumbar spine density, which also looks fine here. So as I was saying earlier, the diagnostic criteria for osteoporosis is focused on vertebral fracture assessment. And vertebral fracture assessment is done through Jayanth semi-quantitative scoring, where you have mild, moderate, and severe deformities, either as a wedge, biconcave, or crush deformity. In our cohort of patients with DMD who are on steroids, we tend to use a 15% height reduction cutoff as opposed to the standard of 20 to 25%. I'll show you the evidence why we started doing that in the subsequent slides. So what is the role of Z-score? Yes, a Z-score less than -2 in children indicates low bone mineral density, but unless there is fracture history, it is not classed as osteoporosis, because children can have low bone density for various other reasons. And it's important to look for adjusted bone mineral density in children, which is adjusted for their size. So what are the clinical consequences of fractures? So this can be different for different types of fractures. With vertebral fractures, they can experience chronic back pain, progressive kyphoscoliosis, as well as this can affect the kyphoscoliosis indirectly and the pain directly, the respiratory function of the young person. With long bone fractures, you may risk accelerating loss of ambulation, which would be very detrimental to the bone as well as muscle health. And prolonged periods of immobilization to heal fractures, once again, can be detrimental. And it is challenging casting patients who've already lost their ambulation. And there certainly are some acute complications as well. So fat embolism, which has a very high mortality of 5 to 10%, is something which has been reported in young people with DMD. Now, why is this? Because steroids not only reduce osteoblast formation, they direct the mesenchymal cells to become adipocytes. So there's a lot of fat in the bones of young people with DMD, which can embolize when they break. And again, surgical complications of anesthesia because of rhabdomyolysis, myoglobinuria can be quite life-threatening. So once we've done the baseline assessment, where do we go from here? So we need to do annual vertebral fracture assessments. This can be done on a DEXA or an X-ray, depending on whatever is available easily. And this must continue as long as the young person is on glucocorticoid therapy. Then a DEXA scan is recommended every 1 to 2 years. We do it annually, but if there are financial constraints, it can be done once in 2 years. And calculation of Z scores. So we need lumbar spine corrected, and whole body is the standard. So height velocity monitoring is again extremely important because it's only with growth that you will see vertebral fracture healing along with bisphosphonate therapy. If they're not growing, you will not see a significant improvement in healing. So symptom tracking, especially of back pain, is extremely important, whether it is just asking them if they have back pain in clinic and palpating the spine, or whether it is using a validated tool. Both are equally acceptable depending on the clinical scenario you're working in, but it's extremely important to assess this. So back to our patient. So as you can see, at around 9 years of age, 9, 10, he stopped walking. Unfortunately, his bone density dropped significantly at this point, as you can see, both the lumbar spine. The adjusted density is actually not classed, not below -2, but still you can see the difference between the year 9 DEXA and the year 10 DEXA. And he's starting to develop vertebral fractures here, as you can see here and here as well. So again, at this point, assessing pain, whether it's using a validated tool or diaries or questionnaires, it's really important to do that at each clinic visit. So this is a different patient. I just wanted to show this to highlight the impact loss of mobility has on bone density. So this is a child who was mobile until 10. And once the mobility goes down, you see a drastic drop in bone density. And this is a very nice study done by my colleague, Nicola Crabtree, who's a DEXA scientist in Birmingham, who has an interest in Duchenne muscular dystrophy. So she looked at a cohort of health. This is a PQCT of the tibia. She looked at a cohort of healthy boys with DMD who remained mobile, and those who lost mobility. So as you can see, even at baseline, there's a significant difference in the size of the bone here. And then as they lose ambulation, a year later and 2 years down the line, the significant loss of trabecular bone here. If you compare this to normal and those who are mobile as well, the ones who lose mobility have significant drop in trabecular bone mass. So coming to the stabilization phase, what's the first line of therapy? It's IV bisphosphonates, be it pamidronate or zoledronate. Zoledronate is a more convenient dosing regime of every 6 months. Oral bisphosphonates are not recommended in children, be it DMD or osteogenesis imperfecta or any other condition. I'll come to why that is in a minute. And monitoring, once you start treatment, monitoring response is important, both on VFA and DEXA scans. So vertebral reshaping is a very important treatment goal in children with osteoporosis, and this is not achieved through oral bisphosphonates. This has been shown in several studies. So IV bisphosphonates are the preferred treatment in children. And again, IV is better tolerated because there can be GI side effects, reduced absorption with oral. So the preferred treatment is IV. So now coming to the maintenance phase, once we've achieved the goal we want, which is, be it improving bone density or halting or improving vertebral fracture or vertebral remodeling or, gaining bone density, we then have to think about where we go from here. So if the bone density is starting to go too much on the higher end, you can then think about whether you want to lower the dose or decrease the frequency. So some centers lower the dose from 0.05 per dose 6 monthly for zoledronate, for example, to 0.025. Whereas our practice in Birmingham has been to decrease the frequency because a lot of our children come from very far away. So we feel maybe going from 6 monthly to 9 monthly or 12 monthly is more convenient for the families. Again, this has not been studied in any randomized controlled trials as to which approach is better. Now, then the treatment duration again depends on the treatment goal, what you have achieved, where the young person is in terms of growth and puberty, and what the long-term outlook is. And again, this can be monitored through annual DEXA scans and VFAs. So again, back to our patient. So this was at 9 years of age. And then unfortunately, by the time we started treatment, he had developed more significant vertebral fractures. Although on treatment, you can see the bisphosphonate lines here and you can see some remodeling here. So although we started treatment at around 10 and a half, 11 years of age, the remodeling actually occurs once they show some growth. He was late going into puberty, and only when they grow, you see vertebral fracture remodeling, and the bone density goes up significantly with testosterone effect in puberty. So early pubertal induction is also very important in boys. So this is a study we did looking at spinal deformity index, which is basically a total of all the vertebrae which have fractured and the total score of the burden. So the green is the boys where we started treatment early, and the red line is the boys where they had significant advancement of fractures before we started treatment, like the case study I've been presenting. So we saw that when we start treatment very early, the burden of vertebral fractures is low and they heal better. Whereas the later we start treatment, the SDI continues to increase and we are unable to close that gap. So this study from our team, there's been a handful of similar other studies based on which the upcoming 2025 guidelines will actually recommend starting treatment early on, as opposed to what was said in the 2018 consensus guidelines. There's also some discussion about starting treatment even before the first vertebral fracture occurs and at the time of starting oral bisphosphonates. However, this will not suit all healthcare systems. For instance, the UK has a bit of resistance to this because the NHS resources are limited. We don't think in the NHS setting we can start everyone on treatment before there is a fracture. So that's open for debate. So this is another similar cohort of boys we looked at where a portion of them were on 10 days on, 10 days off steroid treatment, which I know increasingly people are moving away from, but there are still a group of patients who are on it because we know the bone morbidity is less in this group. So we compared them to those on daily who had mild fractures, which is in the dotted line, and those who had severe fractures in the solid line when we started treatment again. So the mild ones, if started treatment early, they behave more like the 10 on 10 off, whereas the severe ones continue to have an increased spinal deformity index. So we've heard bisphosphonates are very good. We should give them early, but I really want to put this caution out there as well about bisphosphonates. This is something which is unique to boys with Duchenne muscular dystrophy. The top right-hand report here is from my colleagues in Southampton, and this one is from my colleagues in ORDI, and this is one from European Center. These are the reported cases, but in UK we have a very closed very good network of bone doctors in a pediatric bone group where we discuss all the cases. And unfortunately, all of us have experienced the severe reaction that we see only in boys with Duchenne muscular dystrophy. So we are all extremely cautious in giving, and a lot of the centers admit them, give them, a lot of IV fluids before doing that, because hydration is thought to be one of the factors which contributes to this. But it's important to be aware of this. And it's not something which is only seen with first, it has also been seen with subsequent infusions. So it's really important, in addition to routine monitoring, which is renal function, calcium, phosphate, 25-hydroxy-D, dietary calcium adequacy, we look at other factors as well in this particular cohort. Stress dose hydrocortisone, especially for the first infusion, is extremely important. Again, a lot of the centers do IV hydrocortisone, but we tend to do oral. And again, ensuring adequate hydration and a baseline echo and ECG, they are usually under cardiology. Just make sure the last, ECG or echo is normal because of this concern of arrhythmias and intracardiac thrombus. And a lot of the centers, as I said, admit them overnight and keep them for a day or two. But our center is a high volume center. We did not do that. But we did educate patients and families that any concern, they have to come and get admitted, have a low threshold for that. So just while I'm on the topic of steroids, I'll just get that out of the way. So hydrocortisone, stress dose, weaning, and assessing the HPA axis, I just wanted to touch on. It's very important that these boys are and families are educated about stress dose hydrocortisone. So there's two ways of doing this. When they have infusion or illness or anything, you can either give a standard hydrocortisone dose, the 30 milligram per meter square, which we do for other adrenal insufficiency boys, or we can, if they're on a bigger dose of prednisolone than that, you can ask them to split it into a 12-hourly dose to get more cover through the 24 hours. And if they're acutely unwell, they have to get admitted and have the IV dosing. So when you're tapering prednisolone, again, there are specific guidance. You have to take the doses down very slowly, 2.5 to 5 milligram every 1 to 2 weeks, until you've reached the 30 milligram per meter square equivalent of hydrocortisone. Then you switch them over to hydrocortisone and wean very slowly over 3 to 4 weeks to the physiologic doses of hydrocortisone, and then only assess cortisol at 8 a.m. after they've been off all steroids for 24 hours, or an ACTH stimulation test, because I've seen a few patients who've had like 8 a.m. cortisol and ACTH when they're on steroids. This will be suppressed. There's no point doing that. So yeah, again, triple dose, those are just some suggestions of the equivalents of prednisolone, deflazacort, and hydrocortisone. Vamorolone, I'll talk a little bit about. We don't know what the equivalent is yet because it's a new drug. So briefly about growth and puberty, because we can't finish talking about bone health in DMD without including that. Growth is affected even before we start steroid treatment in some of these boys, which is further exacerbated by steroid treatment. Growth hormone is not routinely indicated unless you prove that the young person has a growth hormone deficiency. There have been several groups who've tried this, but it does not actually affect the final adult height. And puberty, again, delayed puberty is very common, and hypogonadotrophic hypogonadism because of steroid use, be it brief or permanent. But long-term hypog is very infrequent, but most of them will need steroid boost just to kickstart puberty. And this growth also helps in bone density and vertebral reshaping. So we would start that early, sort of 13 years of age, rather than waiting until 14 and then considering testosterone treatment. So the final phase is discontinuation phase. So who are we going to discontinue treatment on? This is not an easy decision or discussion. It has to be a multidisciplinary discussion and discussion with the family. So what are the aims? So if they've been fracture free, if you have a good bone density, if they've completed growth and puberty, then this is something we can discuss with the families. However, once we stop treatment, there may be a rebound fracture, which is why it is important to continue to monitor them. And especially the first year or two after stopping bisphosphonate therapy, if it is stopped, you have to be more vigilant. There is no concept of drug holidays in boys with Duchenne muscular dystrophy. This is something they do in adult osteoporosis in patients who've been on long-term steroids. Whereas if the patient is a high-risk DMD patient, then you don't have to give them drug holiday. You can just continue them on treatment. So it's either a stop and see what happens or continue treatment. There's no such thing as I leave them off for 4 years and then start them. It's not a predetermined decision. You just have to be guided by what the bone density does and whether there's any fractures. And again, as I mentioned earlier, individual patient assessment is important. It's not a one size fits all. So this is the last part of my talk. Just want to briefly touch on the future direction in bone health. So as I mentioned earlier, based on a study with vertebral fracture cascade, so increasingly the move will be towards intervening before the first fracture, be it vertebral fracture or long bone fracture. And now we have what are called as the dissociative steroids, which is vamorolone, which we are currently using in the UK. And then I'll talk briefly about alternative agents, which is the denosumab, which is a rank ligand inhibitor, and other anabolic agents such as teriparatide and sclerostin inhibitors. So vamorolone, as I said, is a dissociative steroid. So it does not have the bone toxic effects that the other steroids have because of a slight chemical change. So there have been several studies, and this is the most recent one where they've assessed vamorolone effect over 48 weeks in boys with DMD. So they were either given vamorolone who were steroid naive, or they were switched from prednisone or prednisolone to receive vamorolone. And in all groups, what they saw was improved bone turnover markers. So the bone suppression, which you're seeing here on the steroid group, once they switch over, this was a crossover trial, it improved significantly. And in the vamorolone group, which was 2 doses, the 2 milligram per kilo and 6 milligram per kilo, you can see that the bone turnover markers remain stable. So this is bone protective. Whether this translates into maintaining normal bone architecture, reducing fractures, I think we have to wait and see. In clinical practice, what we've started to seeing is that a significantly higher lumbar spine BMD in those who've switched to vamorolone, but they still have vertebral fractures. So we need to still treat them for that. So maybe it is, we have to decide whether the frequency will be lower, whether dose will be lower. I think the biggest added advantage of vamorolone is also that it improves height STS. So this is height in patients on steroids, the low dose vamorolone and high dose vamorolone. And as I was saying earlier, when they grow, that improves vertebral remodeling or vertebral height regain. So that is also an extremely important feature. The downside, I think we still have adrenal suppression with it, and the BMI gain is thought to be slightly higher than what it is with the conventional steroids, which again, some of these are still out to be seen which way it goes. This has been now FDA and EMA approved for over 2 and 4 years respectively by the two agencies. So denosumab, so it's an anti-rank ligand antibody, and it is thought to have a protective effect, not only against glucocorticoid-induced bone loss, but is also thought to promote muscle function. But this is in the mouse model. There are only scattered case reports in clinical practice. However, in the pediatric world, certainly there remains significant concern about the rebound hypercalcemia. This is the case series we reported a few years ago when we saw a series of young people around 18, 19 present to our center with renal failure and hypercalcemia, when we learned that they had been on the giant cell tumor denosumab trial. So after we reported this, the MHRA put a ban on denosumab use in children, and it's still not been lifted in the UK. So it is not being used in children. And because BMD is a low bone turnover condition as opposed to some other conditions, it was generally felt that maybe the rebound hypercalcemia would not be as bad. So Leanne Ward, who is a bone specialist in Canada, who also led the consensus guidelines for DMD in 2018, has done a trial of denosumab in boys with DMD. However, she has not found it promising. The results are not out yet, but I've heard that there is still rebound hypercalcemia, so you have to be extremely careful. So I was part of this global expert guidance document recently where we provide some guidance for safe use of denosumab, because it is still a useful drug in certain conditions such as giant cell tumor of the bone or aneurysmal bone cyst or granulomas, where they are not amenable to surgery, but certainly not for other conditions. And we were also in Birmingham part of the osteogenesis imperfecta trial for denosumab, and we had to stop the trial abruptly because of the serious hypercalcemias we saw in a cohort of patients. So what other anabolic therapies are there? There is teriparatide, but it is a very weak anabolic agent. And also we need to remember, for someone who's been on bisphosphonates for so long, where we are actually reducing bone turnover, then giving a drug which stimulates osteoblasts is going to take a long time to work. So it is even less effective if given after bisphosphonate therapy. So I saw a patient today who was going for spine surgery, who'd been on bisphosphonates and the bone density hadn't improved, and they were considering teriparatide, but this is not a good idea. It's better to give him a few more doses of bisphosphonates. The reason his bone density was still low was because he'd only been on treatment for 2 years. So it is better to give more bisphosphonates than to give teriparatide. I do use teriparatide pre-spine surgery, but this is more useful in those who are bisphosphonate naive. And anti-sclerostin antibodies, cetuximab and romosozumab, have been very promising in adult osteoporosis studies. There are trials in children underway in OI, but so far there has been no experience of these drugs in DMD. So to summarize, progressive muscle weakness and immobility in neuromuscular disorders affects bone health. And in DMD, the added insult comes from corticosteroids and delayed growth and puberty. So the key investigations in osteoporosis surveillance is vertebral fracture assessment. Yes, DEXA scans are useful, but VFA is the most important thing. And early treatment of vertebral fractures is very important to prevent the vertebral fracture cascade and therefore pain and kyphoscoliosis. DEXA scans in children, we do lumbar spine whole body, in adults hip and lumbar spine as recommended by the International Society of Clinical Densitometry. This is what helps aid in monitoring of treatment effect. and bisphosphonates remain the first line of anti-osteoporotic treatment in DMD boys. Thank you everyone for your kind attention. Sorry, Dr. Jayanth, I went first.
That's wonderful. Thank you, Dr. Suma. I think Dr. Santosh, you have any comments on Dr. Suma's presentation or any inputs, any other added points?
Yeah, yes. Very nice talk, madam. It's really eye-opening for me as well, because as madam was telling, just recently I started seeing these cases, maybe last few months. So basically, I've been seeing the adult cases, like, more than 18, 20 years. Like, as you clearly said about, I think bisphosphonates are obviously the first choice when it comes for childhood. For adult patients, like, who have been diagnosed with osteoporosis, like after 18 years, like they have not been on bisphosphonate previously. If the patients are having very severe osteoporosis, or if they have multiple fractures, is it worth to try anabolic drugs like teriparatide before going for bisphosphonates, or we should as we have good data with bisphosphonates, should we initially start them on bisphosphonates itself?
That's a very good question. I think because there's lack of data, we don't know.
Yeah.
It would be good whichever one we do, either bisphosphonates or teriparatide, to sort of religiously document what's happening to the bone density, and just take it from there, really, because there's no clear answer, because no one's ever tried teriparatide first in patients with DMD. And there was one study which I didn't go into details, but they only looked at a small cohort of 6 patients. This was in Cincinnati Hospital. So of those 6, I think 1 was bisphosphonate naive when they gave teriparatide. Rest were bisphosphonate and then teriparatide. They didn't see a big difference in BMD change before and after in both these patient cohorts. So, I think there's no right or wrong answer, but I think we just need more evidence to go straight into teriparatide. We know denosumab works. And in fact, in osteogenesis imperfecta recently, the TOPAZ study, which looks at teriparatide and then bisphosphonate, has been completed. I think the results will be discussed in the upcoming ASBMR meeting, or maybe it's just happened. So it'll be interesting to see what's happening there, because a lot of the things we do in DMD and other rare conditions comes from slightly more common conditions like osteogenesis imperfecta, where there are more studies.
Okay, fine. Yeah. Thank you.
Sure, that's a good discussion. So as I understand that, I think the main therapeutic is based on the bisphosphonates in DMDs.
Yes.
But somehow, in our practice, we don't get to see many DMDs in the orthopedic OPD. Of course, we see till the diagnosis. I'm sure Jayanth also will agree with this experience that they come for diagnosis. We either refer to genetics or ask for some blood investigation. Maximum a muscle biopsy. Once the biopsy comes, suddenly these patients disappear in India. We don't, of course, they come for some respiratory problems and they get admitted in ICU for ventilatory support, and some cascades of events, which a typical DMD in a child, what I'm talking. And in terms of fractures, I rarely see DMDs having fractures in India. This is my experience. Jayanth, you want to add something on children, the way we see DMDs?
I'll do my talk.
Yeah.
Shall I do my talk and then because I've got one of your cases also. So I agree with Rudra in that we don't see so many. I mean, I have seen quite a few children with Duchenne and SMA, but our main neuromuscular problem that ends up with fractures is CP. And there's a lot of evidence to say that the bone mass reduction, the lack of growth, and the weakness of muscles, the effect of all of these that has on bone development, on reduced bone mass and increased risk of fragility fractures is quite similar between CP and I'm sure even Rudra sees a lot more children with CP developing fractures rather than with Duchenne, only because of the numbers, because I think the number of children with CP to Duchenne, it must be like 100 to 1 or something like that. So it's just a much more common and prevalent condition. But I think there's a lot of overlap in terms of orthopedic management and principles of how we manage. So whether it's a non-walking child with CP or a child with Duchenne or a child with SMA, I think the principles of orthopedic management are very similar, and the way we have to approach the problem is similar. So I just have a 5-minute presentation. So I'll just do it. So it just completes the orthopedic side, if that's okay. And
Sure. So the moderators, please.
Okay, Jayanth. I think while you're getting prepared, see, I think DMD in India has got varied presentations. For example, they present to a government hospital in a different way, and a private hospital probably depends on the affordability. And the moment these parents come to know that their child is diagnosed with the DMD, half of them, I think, what they lack is a good counseling in our country and the available resources and treatment. They somehow they give up. That's what I have seen among the DMD parents. They somehow give up on hopes and they shatter because and again, the counseling, who has to do, these are the parts which are, I have seen in my institute challenging. For example, we send it to genetics and neurologist and endocrinologist, and we somehow do some counseling. But again, the definitive counseling is done by the geneticist after the genetic evaluation, and suddenly they are lost for follow-up. This is the observation what I have. Of course, the contractures and difficulty in ambulation, mobility, these are the main areas why we see them often. Anyway, Jayanth, I think you can go ahead with your presentation. We shall discuss later.
yeah, it's just 5 minutes. That's all. It's very quick.
Yeah.
In fact, the first case is, I think, one case that you actually posted from Indira Gandhi. So this is a 7-year-old boy with GMFCS5 CP with a 5-week history of increasing right hip pain. And that is the sort of boy. This is your patient, isn't it, Rudra? If I'm not mistaken. I think.
Yeah, I think so.
Yeah. So this is a common sort of problem that we face in India, where you have a child who is a non-walker, who had a dislocated hip and it's been neglected for some reason. Probably somebody has advised them surgery, but because the child doesn't walk, the parents haven't taken it seriously. And then subsequently has had severe osteopenia because of all the medications he's on, and all the problems that Dr. Suma has outlined. And then now he has a fracture and a femur fracture, and he's in severe pain. And as orthopedic surgeons, we are completely stuck, because if the hip had been fixed, at least we have something to go off. But trying to do anything in this situation becomes totally impossible for us as orthopedic surgeons. So this is you saw the other end, which Dr. Suma was talking about, which is evidence-based medicine, and doing studies and following these children up very systematically. But the problems that we face as orthopedic surgeons in children with neuromuscular disease is just when there is a catastrophic occurrence or incidence, that's when we get into the picture. So this is a 12-year-old girl. This is just a counter example. Developed GMFCS, she had GMFCS level 4 CP, and I reconstructed her hips actually. And 2012, she had a dislocated hip. 2017, she was fine. And then, everybody ignored the fact that she had osteopenia, and she disappeared. And 5 years later, she came to me after the pandemic with a finger fracture. So somebody pulled her finger and she developed a fracture. And then this prompted us to actually look into why she developed a finger fracture, because someone pulled on her finger. And then we found that she had very severe osteopenia. And then we ended up treating the osteopenia, and she had a lot of bone pain. She had problems with standing and walking, and all of these problems were because of low bone mass. And it went completely unidentified. And it was this incidental finger fracture. that actually focused our attention on the real problem that was going on, which is a significant problem in our bone metabolism. So osteopenia and CP, I think it's been dealt with in great detail by Dr. Suma, but these children have a huge number of problems: lack of sunlight exposure, immobility, a lot of immobilization following surgery. And another problem that we face as orthopedic surgeon is inexperienced therapist. And finding good therapists is always a problem. And parents always, and these days with the home therapy and all these physiotherapy apps, they just get any therapist who comes home to do the therapy. And this is a child with SMA, I think. And they just got the parents just got a therapist at home, and child had a knee flexion contractor, and this therapist just pulled on the leg. And then they came to me with a fracture of the proximal tibia. And then we also found that she was vitamin D deficient and she had low BMD in the femur and lumbar spine. And then we corrected her vitamin D, dietary changes, and then got her, immobilized her in a cast for a period of time and got her back to normal. And then, told the therapist, please don't do this. So the consequences of osteopenia and CP are obviously fractures, bone pain, reduced exercise tolerance, interference with therapy. And it's also relevant to the orthopedic surgeon, as Dr. Suma mentioned, because when we are about to embark on intervention, particularly spine fusion surgery or osteotomies, we also want the osteotomy to heal quickly. So having good bone mineral health is extremely important. And this slide I think is very important for all the neurologists and the non-orthopedic surgeons in the group, is if any of your patients with any neuromuscular disease develops a fracture, what should you do? So basically, if you send them to a regular adult orthopedic surgeon, they do not have a complete appreciation of how to treat a child with a neuromuscular condition that has a fracture. So whatever treatment you do, it should allow early weight bearing. If you have a minimally displaced stable fracture, then you just put them in a cast and you start early weight bearing within a week to 10 days. And if it's an unstable long bone fracture, you don't put them in a cast, you fix and you mobilize early. So you need adequate support. You need probably a tertiary hospital, place like Indira Gandhi or Rainbow, whatever a tertiary children's hospital where you have good backup, good specialists who can manage these problems and do the appropriate treatment. Because the problem is, if you have a marginal walker, a single fracture in a lower limb long bone can cause permanent loss of mobility, and you can never get it back. So you have a very, very short window of time, probably 4 to 6 weeks, before you get that child back on their feet. And if the child is not already known to have osteopenia, then you immediately refer them to the appropriate specialist so that they can be diagnosed and treated properly. So interdisciplinary management between orthopod, neurologist, therapist, and endocrinologist, all the specialists who are involved in neuromuscular disease, I think we should be working together to try and prevent these from happening. So low BMD, so these have all been covered very well. So, so as an orthopedic surgeon, instead of doing that, what we would like is to diagnose these children who have dislocated hips or any other problem, and then treat them properly so that they can be back to normal mobility as soon as possible. So, so that's been our experience, and I think the experience between myself and Dr. Rudra Prasad is very, very similar in that as orthopedic surgeons, we tend to see a different spectrum of problems. Thank you.
Thank you, Jayanth. I think it's a very significant message. Especially, I agree with you that, the commonest problem what we see, especially in cerebral palsy, and especially the kids who are on these anti-epileptic drugs and who are GMFCS 3, 4, 5, especially 4 and 5, they're very, very fragile. And I have seen, as you shared, that in the common presentation that, with the physiotherapy going on, and then suddenly they come with increased pain, the child is crying heavily, and there is a fracture. I think all the people who are involved in the management of these kids should be knowing that, the bones are very fragile. They have to handle these kids very, very gently. And I think the treatment is important. Before we move on, Dr. Suma, one question to you. Whatever you presented, does that hold good completely for this cerebral palsy also?
Most of it, sir, because I just focused on DMD, but they all have slightly different phenotypes. But yes, Ulrich muscular dystrophy, Nemelin myopathies, all these, spina bifidas, all the neuromuscular have a slightly similar, but mild variation in how they present, but the treatment investigation remains the same.
Dr. Jayanth, other than cerebral palsy, what are the other rare diseases you have seen with the pathological fractures?
SMA is another very common problem that we see, and they develop a lot of fractures. Many of these fractures even go unnoticed because when we take an X-ray for some reason, we see some periosteal reaction, and then we ask the parents, did you have a fracture? They say, no, maybe a couple of months ago, he complained of a bit of pain. It was there for 2 weeks and then it went off. So because they are not walking, and so they just stop therapy for 2 weeks, 3 weeks, and then the pain just goes away. And so the whole problem just remains completely concealed. So unless, I think, neurologists and therapists and orthopedic surgeons, we actively seek out the problem of osteoporosis and diminish, sort of compromise bone health in these children, and send them for investigation and actually actively manage this problem, I think it will just completely remain under the radar. Many of these children will have very poor quality of life, a lot of pain, and even the parents don't know. I mean, how can they relate Duchenne muscular dystrophy with fracture? In their mind, it's like two different things. So Anne had a question. I think Anne has put up her hand.
Yeah, Dr. Anne.
Sir, I had a question and also a point. Sir, you rightly pointed from both of your perspective that you're seeing more CPs than neuromuscular disorders. But for me, it's the converse is true for me. I have more DMDs and SMA than cerebral palsy. Because I'm primarily a neuromuscular expert, I've been trying to cultivate these patients. So it's over the last 12 years, 80% of my practice is this. So we have around 600 children with DMD, 600 children with SMA, and we are seeing so many fractures. But my disadvantage is 80% of these people are outside Karnataka. They come twice a year to see me. They all have fractures outside my area of influence, my ambit of influence, so to speak. We can only actively tell them. And they often, a couple of times, Dr. Jayanth has come to the rescue. Dr. Jayanth, you know about some of these cases where somebody else is instrumented and then I've said, please go see him again. And that's one point. The second point is that you're going to get more and more of these patients because previously our average lifespan for even something like DMD is 15 years, the national average. But the international average is above 40.
Yeah.
45. And my patients are surviving. And the same will happen for India as well. So the increasing amount of survival means more work for you all. We just don't know how to connect the dots. And that was the reason for having this program.
So one of the things we could do, Dr. Rudra Prasad and myself, is to give us a one-page, like a what to do if your child has a fracture, which they can give to their local orthopedic surgeon to say, these are the principles of management, because an orthopedic surgeon will be able to easily manage these fractures. They just need to be told how. So the generic skills of managing these fractures, any orthopedic surgeon will have.
Is it possible to write up something between, because your name carries weight?
We can write up something that we can give to all the parents in case there is a fracture. You don't have to come all the way to Bangalore. Go to your local orthopedic surgeon. Tell them, Dr. Rudra Prasad and Dr. Jayanth gave me this leaflet to give to you. And please manage this fracture like this. He can do that. I mean, it doesn't have to be very specific, but we can give them general guidelines as to how to go about fixing these fractures or not fixing them. We have an orthopedic language which we can speak and we can explain to them. That's possible.
Then should we make it, so for example, Dr. Rudra Prasad, when we collect data, we always collect data on bone health, DEXAs, vitamin D, how many bisphosphonates given. We also have data on hip dislocation and things. Should we then make it practice to say they get automatically, they get seen by either you or Dr. Jayanth? just a one-off preemptive that they have to do it in their checklist of things. They know their checklist is they have to be seen by the cardiologist and the pulmonologist at some point. I invariably send to Dr. Jayanth only when there's a problem. I don't send before. Do you want me to send before? So that you have a leaflet given, they've seen once, so that it is imprinted. So what we see in Dr. Rudra Prasad, sir, is that they come and tell me after the fracture has happened. We were able to rescue a child, and most of them stopped walking with that. We were able to rescue one of the children that I stated the story of in the beginning, because he came to us within 1 week of the fracture. And we were then able to salvage it and put, within 2 weeks, we were able to mobilize. And basically, I inadvertently made an enemy of that orthopedic surgeon. I don't want to do that. It puts me in a really awkward position as a non-orthopod. Should I send it to, is that?
Yeah. So I think if you are in connection with each other, as and when, if there is any problem like this, probably we can come. I think you don't have to send them before the fracture, especially when there is something like an event of injury. Probably you can connect. Nowadays, connection is not a problem. WhatsApp is there.
Sir, we never get to know when they have injury. I see them twice a year, 6 monthly. And that is how we have long follow-ups. I have patients more than 10 years follow-up only because they know they only have to come twice a year.
I'm really surprised that you have so many DMDs in India, because I've never heard from anybody. This is the first time I'm hearing.
There's an approximate 2 to 3 lakh DMDs in our country and 2 to 3 lakh SMA.
I know that, but see, to be frank with you, practically, because I've been in Indira Gandhi since 98, 2000. And these kids come after the diagnosis, they disappear literally, let me tell you. I think they come up to around 9-10 years with some other problems, contractions.
My oldest is 28, like sir. 28-year-old patient, oldest.
But we never see them. I don't know where. Probably everybody are going to Annie. I don't think so. Anybody is going to any other neurologist.
I think no, sir, you're doing a good job as well with the bisphosphonates, so they don't come to you with fractures.
Sir, that's not the point. Is that we have more centers and more people. Like you rightly said, it is all about the counseling. If we give them hope, they usually come back. They're only coming back for the hope that we give.
I think that is what we need to do first, Annie, especially because I work in a government hospital. And what is most important is we have to sensitize the primary care people and the tertiary care, especially so-called, also to be very sensitive. Because DMD is one thing, I feel very sorry to say this, the moment the diagnosis comes, it's like, the whole fraternity is giving up on this. That's what I have seen. This is my sense. Very few people like you and Dr. Suma and Dr. Jayanth, maybe you people are doing and seeing some patients, but majority of them, I am sure they are disappearing. Disappearing in the sense like, the rural people, especially who are coming with the DMD, and they don't come for even follow-up also.
Sir, we have rural people coming from Indira Gandhi for follow-up, sir.
No, it's for the orthopedic problem, I'm telling, orthopedic problem, yes. Especially with the fractures, I don't see them so often.
But that is why I'm asking, if I send them to you, because there is a validity, there's a sanctity to sending it to you. Even if it's only one-off, and you're giving a document, it carries a weight which my name doesn't carry. If you are giving a document saying, this is it, they'll have a little bit of fear that, you and Dr. Jayanth said this, that they should not do something. Otherwise, it's difficult when I'm saying it.
Yeah, certainly. It may be definitely it's a good idea. We are always there. And we are, 9 to 4, we are there in the hospital. Even otherwise also our team is there. Anytime, we'll be happy to get involved with some research work also in DMD, because I don't think so in India, many of the experiences are quite rich in DMD. But of course, cerebral palsy, we commonly see. Jayanth also is, treating regularly. But DMD is one thing I have not seen much in my practice, especially the fractures. I don't remember managing any fracture of DMD. How frequently do you see fractures with DMD? Because you have so many patients.
Quite often.
The literature, about 60% of them have a long bone fracture. And 60%.
So the saddest is not that. Sometimes I get new patients at age 16. Every part of their body is in pain. That is so painful for us to watch it. You touch their finger, they're in pain.
Yeah.
And you feel like we should just do palliative care for them. It doesn't matter how good their heart is.
Older children with DMD will not, more than 12, 13, they will not let you even examine their legs. You cannot even, they are in that sort of Buddha position with the knee flexion contracture. And you can't even straighten their legs. They will just say, please don't touch my leg.
Yeah.
But even fingers hurts.
Yeah. So maybe we should do something. Yeah.
I'm hoping, sir, you want numbers, the numbers are there. You have any people, juniors who want to do anything, you're more than welcome, very happy to collaborate, sir. And Dr. Suma is also very interested. Dr. Jayanth is very academic minded. You think about something, and we have data which we store and keep. We collate the data and store and keep. It's not lost. You're very welcome to come up with something. I hope we can do something.
Yeah, that's good. Jayanth, what about bisphosphonates in cerebral palsy? How often are you using? And are you just managing for the fractures and vitamin D, calcium supplementation, or bisphosphonates and teriparatide? How is the other denosumab injections? I know that you, as Dr. Suma, shared her experience. I mean, the talk on the denosumab in children and other things. What about teriparatide? Are you using teriparatide in children with CP?
No, because I checked with my endocrinologist and she said the only licensed safe medicine is palmitonate or zoledronate. That's what we are using. I use a lot of zoledronate now pre-op before surgery. But otherwise, there is no routine screening program for all children with CP. But again, most of the GMFCS level 5, 4s and 5s come to us only if they need intervention. We don't see, like the neurologists, we don't see the regular follow-up of the GMFCS 4s and 5s. Only if they have a dislocation or if they have contractures or a fracture, some problem, they actually come to us.
We give bisphosphonates for CP.
So
Sorry?
common practice as well.
We give bisphosphonates. Yeah.
So I'm using it pre-op, before hip reconstruction surgery or osteotomies. I'm using zoledronate.
No, I'm doing it surveillance. We do surveillance and give bisphosphonates.
So we don't do profile. So there was a nice study by Nick Shaw, my colleague, and Zulf Mughal from Manchester, where they have shown that after one fracture, you can start treatment. We do 3 infusions, 6 monthly for 1.5 years. That usually prevents fractures. If they have another one, then you can do the cycle again. Other centers in Canada and Australia, what they do is, if they start treatment, they then give a very low maintenance dose of 0.025 per year for a few years until they complete puberty. So nobody gives them prophylactically, but if they have the first fracture, then you can give it. Some wait till they have had 2 fractures, but generally it's been moving towards now giving them after 1 fracture. Not teriparatide, only zoledronate.
So Dr. Santosh has got a patient, one of the patients we transitioned, Dr. Santosh, who was after bisphosphonates, lots of pain, post-scoliosis, 22-year-old gentleman. He was a child when he was with me. Now he's 22. He's from the Adivasi Tribal Center. And you had started him on teriparatide, Dr. Santosh.
Yeah, I just started, but I'm not sure how. I think
I reviewed him. After 1 month, his pain was much better. He was in terrible pain.
So like following bisphosphonates, we need to, as Madam was telling, Suma Madam, the efficacy of teriparatide is not so good, like as compared to when we start teriparatide as a first drug. So that's why, like, maybe on follow-up DEXA scan we need to see like how how he's responding, because teriparatide in short term is known to reduce the pain also because it's been used, but on the effect on I think the bone mineral density we need to see on the follow-up scans.
Dr. Santosh, question for you, just on behalf of everybody. What bisphosphonates are you using? Do you use zorendonic acid in children? What is the dosage and how often?
So we are using zoledronic acid itself. So yeah,
You don't use palmitonate?
No, sir, we are not used. Like most of them are on zoledronic acid only. As Madam was telling, the dose is the same, like 0.05 mg per kg. That's the dose. So that's what we are doing.
And another question for you, both Dr. Anne and Dr. Santosh, because if people are practicing here, we don't have a standardization for DEXA scanning, for children. How? Because many of the centers, wherever I'm sending, I don't get the Z-score specific for children. There is no control. So how do you manage it? What is your interference?
Narayana.
Inference?
Bye.
So please send them to Narayana. I'll give you a report.
I think that's very important. I think, the machine also plays a role.
Yeah,
And
Narayana, I know, but we need some, because of the place where I am practicing is in Indira Gandhi. But I was not aware in Narayana this is available anywhere else. And what are the differences? Is it the standardization based on Indian children, or how is it?
No, sir. So Narayana, I started after I came. So there was a DEXA machine, but generally what happens is it's a DEXA technician doing it. It's not someone who's trained. So very few people have specific bone training. So even the DEXA company who trained the technicians, I had to call and train when I started in Narayana. So that's my experience. And centers are doing different sites which are not recommended in children. And there is recent reference data from a Pune team, but it's specific to a machine called GE Lunar iDEXA. No other center in Bangalore has that. So we can't use that reference data unless they adapt it to specific. Like the most common one I've seen is Baptist. They have a Hologic, and in Narayana, we have a GE Lunar Prodigy. But the data I use to normalize is the Alphabet study, which is the reference data from Birmingham, where we had in a 4,000 cohort, we had 350 children who are Asian, South Asian, Indian. And so I use that reference data and size adjust and provide a report.
So probably, yeah, because it's the Asian reference, probably it will be more specific for our practice. Thank you so much. Yeah, that's a useful information, because I was really feeling difficult in interpreting these reports, given by the general DEXA machine. So any other comments or any other points, Dr. Annie and Santosh?
Just one question to Madam. Like, what's the duration? Ma'am, you told about the duration of therapy, but in adults, because we know all these neuromuscular disorders, they are inherently have a very high risk of osteoporosis and fracture. Even after long-term treatment, will we reach a stage where we can discontinue, or we need to continue
But
them?
our common practice, at least 50% of our DMD patients, we discontinue treatment at transition, because we've achieved a state where, especially if we start treatment early, they've had vertebral fracture remodeling. We are at a point where the bone density is normal, and some of them stop steroids at that point. So those are the cohort who will qualify to stop treatment, and we keep a close eye. Others where they've not completely healed, very delayed puberty, delayed accrual of bone mass, and continued steroids. So those are the people where we have to continue, and our adult colleagues used to continue until, the steroids are on or bone density is better.
Dr. Suma, sorry, one thing. Previously, we used to stop steroids on non-ablation.
Yeah.
But now that we've moved away in the muscle world from that.
Yeah.
So in the last 4 or 5 years, even if it's what we tend to do is reduce the steroid level. So they might go up to 30 mg, but we'll slowly reduce it and maintain it anywhere between 15 and 12. Yeah. And leave it at that. That is left for lots of protective reasons. So we hardly ever take off the whole drug.
Yeah, I think which is why a lot of them these days just continue on bisphosphonates as well, because they're continuing on steroids.
So that's wonderful. I think if there are no questions, can we conclude it, or we have any other points?
Sir, before concluding, may I just say a thank you to all of you? Vote of thanks.
Yeah, please go ahead. Yeah.
So thank you so much, sir, for giving us your valuable time, Dr. Rudra Prasad. Thank you, Dr. Santosh. Dr. Santosh, actually, I have to say a big thank you to you, because we found as pediatricians it's very difficult for us. We're all pediatricians, very difficult to let go of our patients. And so we found a very compassionate person in you who could take over the care of our children. Thank you so much for that, and thank you for
I should
all
be
the
very thankful for you, man, for all sending the patients, and also to be a part of this discussion. Also, it's a very nice discussion. I learned a lot of things actually. Thank you, ma'am. Thanks.
And thank you, Dr. Jayanth, for always being there and helping us out, and and for your academic interest. Thank you, Dr. Suma. That was a fantastic talk. Thank you, everybody. And thank you, finally, not but least, thank you, ORDI, for continuing to support us on this journey. Thank you.
Thank you very much. Thank you all.
For organizing and